idiopathic intracranial hypertension. There is a special talk on this. That is why we are taking this. But generally, the question will be from headache only. Okay, and one of the diagnosis will be IIH. Okay, so here, what is the core concept for IIH? It is a rare condition where there is an increase in the intracranial pressure. There is no mass lesion, no hydrocephalus. CSF composition is normal. Diagnosis of exclusion in pregnancy with headache. So you have to exclude many other things before making this particular diagnosis. So generally, typically, you will see this in obese women of childbearing age group. Female to male ratio, it's 8 is to 1. Incidence is 0.1 per 1 lakh, and incidence in obese women is around 20 per 1 lakh. Okay, it is increasing because of the increase in the obesity in pregnant population. Okay, now pathophysiology, it is related to the CSF dynamics and abnormality. There is increased production or there is a decreased absorption at the choroid plexus or arachnoid granulation level, and that is why there is an increase in the intracranial pressure leading to the papilloedema, and there is a headache. Okay, so clinically the patient's presentation is headache. It is daily throbbing or retrobulbar headache. Visual obscuration may be there. It may be transient. There can be visual loss which is progressive. Diplopia due to the sixth nerve palsy. Nausea, vomiting is common. Photophobia may be present, and tinnitus, vertigo may be possible. Okay, so papilloedema because of the increase in intracranial pressure. Enlarged blind spot can lead to the visual field defect. There is a decreased visual acuity because of the optic nerve involvement, and sixth nerve palsy, there is a false localizing sign. So sometimes this sixth nerve palsy can also be given in this scenario. Then think of this IIH. Okay, so papilloedema is the hallmark. Okay, so symptom mainly because of the increased intracranial pressure, that is headache, visual symptoms. Neurological symptoms may not be there except sixth nerve palsy. CSF pressure will be raised, which is normal composition, and imaging will be normal ventricles. There is no obvious mass. Okay, so treatment is a lumbar puncture. Opening pressure is more than 25 millimeters of mercury. Then CT brain will show you have to exclude the mass lesion. MRI, MRV will exclude your CVT. Visual field testing is required for monitoring the progression. Okay, so what about the safety? We have already discussed along with the headache that CT head is safe. MRI is preferred, especially if you want to rule out CVT. Then gadolinium can be used during pregnancy, but one should be cautious. Okay. Then differential diagnosis, preeclampsia, eclampsia, CVT, intracranial tumor, meningitis. So IIH is the diagnosis of exclusion. Okay. So generally there are no obstetrical complications. There is no need for termination of the pregnancy. Visual risk is same as like a non-pregnant lady. Is there any effect of pregnancy on IIH? Generally, disease course may worsen, and it is related to the weight gain during the pregnancy. Timing, often early pregnancy, and recurrence risk is not increased. Okay. What are the management principle? Main goal is to control the symptoms of the patient and preserve the vision. Approach is multidisciplinary. It will involve the obstetricians, neurologist, ophthalmologist, and anesthetist. Okay. So advise weight control. That will also help to reduce the intracranial pressure and limit the weight gain to less than around 20 pounds maximum. Then paracetamol for the relief of the headache. It is safe during the pregnancy. NSAID is a good analgesic, but to be avoided in the third trimester. Acetazolamide will reduce the CSF production. It is category C, but can be used. Then loop diuretics. CSF production is reduced because of the loop diuretics, and short terms they are safe. Steroids, they are used in acute cases, but it has got a limited role. Okay, so in the drug acetazolamide is a key drug. Avoid thiazides because it causes FGR. That can also be asked in the SBA. Opioids we have to use in with caution. Okay. Then surgical management, repeated lumbar puncture may be required. That can cause give the symptomatic relief. Then optic nerve sheath fenestration for visual deterioration, and CSF shunting in refractory cases. Okay. Lumbar puncture is safe in pregnancy. It is got a diagnostic as well as therapeutic role. because CSF composition will be normal here, okay, in IIH. It is safe in pregnancy. It can be repeated. Okay. Mode of delivery is vaginal delivery. More than 50% cases, the patient can deliver vaginally. Caesarean section is not indicated. Decision is for obstetric indications only. And intracranial pressure in labor, there is a transient increase, but it is not harmful. Okay. As far as anesthesia is considered, spinal is safe. Epidural may increase the intracranial pressure. General anesthesia will increase the risk of ICP, rise in the ICP. So special caution, lumboperitoneal shunt may lead to the risk of damage. Then what is the monitoring which is required? Visual field every 2 to 3 months. Neurology review should be regular. Obstetric care is routine. Growth scans only if indicated. Postpartum breastfeeding can be continued. Acetazolamide is safe. Paracetamol is safe. And NSAIDs can be given. Ibuprofen is preferred. Then coming to the contraception, caution with progesterone only methods. You need to have embryo discussion before giving progesterone only methods. Okay. Then complications, visual loss is seen in around 10 to 20% of cases. Permanent blindness is rare, but it can happen. Then this is the quick revision table. So this is the diagnosis by exclusion. Hallmark sign is a papilloedema. Key investigation is a lumbar puncture showing more than 250 millimeters of water as a pressure for the intracranial pressure. Best drug is the acetazolamide. Delivery by obstetric indication. Risk is very rare, but there can be visual loss also. So take home message is a papilloedema plus normal imaging. Think of IIH. Lumbar pressure, lumbar puncture pressure more than 250 millimeters of centimeter, 2 millimeters of 250 millimeters of water. Then MRI and MREV will be required to rule out CVT. Acetazolamide can be used. No need of cesarean section unless there is obstetric indication, and main risk is a visual loss. Yes, doctor.
A 28-year-old obese primary gravid at 18 weeks presents with daily headache and transient visual obscurations. Examination reveals papilloedema. MRI brain is normal. Lumbar puncture shows opening pressure of 280 with normal CSF composition. What is most likely diagnosis? A. Migraine. B. CVT. C. IIH. D. Brain tumor. E. Preeclampsia. It is C. IIH.
Yeah, always there will be one EMQ on the headache. Okay, so answer is
Yes.
IIH. There is a classic triad: headache plus visual symptoms, papilloedema, increased CSF pressure with normal composition. Normal imaging will exclude tumor CVT. Diagnosis by exclusion is IIH. Next.
A pregnant woman is diagnosed with idiopathic intracranial hypertension. Which of the following is most appropriate first-line pharmacological treatment? A. Mannitol, B. Acetazolamide, C. Furosemide, D. Dexamethasone, and E. Sumatriptan. B. Acetazolamide.
Yes. So acetazolamide is the drug of choice. It reduces the CSF production. Carbonic anhydrase inhibitor. Okay, safe enough in pregnancy when indicated. First line for symptom control plus visual preservation. Next.
30-year-old woman with IH at 38 weeks asked about mode of delivery. She's asymptomatic with stable vision. What is the most appropriate advice? Elective C-section at 38 weeks, induction of labor at 37 weeks, vaginal delivery unless obstetric indication, avoid labor due to increased intracranial pressure, E forces delivery mandatory. It is C vaginal delivery unless indicated obstetric indication.
Correct. So vaginal delivery unless obstetric indication. Okay. So IH is not an indication for cesarean section. Labor related ICP rise is transient and can be managed. Mode of delivery for obstetric factors only. Next.
Which of the following is hallmark clinical sign of IH? A neck stiffness, B papilledema, C hemiplegia, D aphasia, E ataxia. It is B papilledema.
Correct. So IH will typically have a papilledema. Papilledema is a key sign of raised ICP, essential for diagnosis, very commonly tested SBA point. Okay. Next.
A pregnant woman with suspected IH undergoes imaging. Which investigation is most useful to exclude CVT? A. CT scan without contacts. B. MRI brain alone. C. MR venography. D. Skull X-ray. EEG. C. MR venography.
Yes, many times repeated. Okay, when you think about CVT, always MRV. CVT is an important differential. So CT may miss CVT. MRV is the best test to exclude venous thrombosis. Next.
A woman with IH complains of diplopia. Which cranial nerve is most likely affected? It is cranial nerve, sixth cranial nerve is affected.
Yes, correct. So papilloedema, diplopia, sixth nerve affection. Okay, obese lady, think about IH. Okay. Sixth nerve palsy is common due to long intracranial course. There is a stretching. Okay, this is known as false localizing sign.
Which of the following
Oh,
complication
just
is
wait,
more?
doctor, just wait.
Yes.
Yes, question number 7, doctor.
Which of the following complication is most important to monitor in IH? A. Seizures, B. Visual loss, C. hemorrhage, D. Stroke, E. Infection. It is B. Visual loss.
So what investigation you have to do?
Uh, Visual field is checked every 2 to 3 months.
Yes, you have to monitor the visual field. So major complication is a visual impairment around 10 to 20%. It can be permanent if untreated. It requires serial visual field testing. Okay. Next.
A 26-year-old pregnant woman with IH is planned for analgesia in labor, which is the safest option. A. General anesthesia. B. Epidural with large volume. C. Spinal anesthesia. D. No analgesia. E. Ketamine anesthesia. The C. Spinal anesthesia.
She's asking for analgesia in labor.
Analgesia.
Analgesia,
It
I think
is
then
ep-
because spinal we don't give for
for
analgesia purpose.
analgesia.
So I don't know what
But
is expected.
epidural and general,
Yeah,
epidural can increase
correct,
ICP.
correct. So let's see. It is a spinal anesthesia. It is safe. Epidural may increase ICP. General anesthesia risk of ICP is increased. Regional is preferred. But practically, this SBA doesn't fit into the practical scenario. This is
Yes,
my
sir.
personal opinion. Okay.
Yes, sir.
Next.
Which of the following statements regarding IIH in pregnancy is correct? Pregnancy is a major cause of IIH. Termination improves the prognosis. Visual outcome worsens in pregnancy. Diagnosis is by exclusion. CSF composition is abnormal. The diagnosis is by exclusion. And even visual outcome.
Worse in pregnancy, but it is seen in 10 to 20% of cases, and complete visual loss is rare. Okay.
Okay.
So, which of the following statements regarding IH in pregnancy is
Then it
correct? So,
will be
most
D, sir.
likely, see, this is sure that it is diagnosis by exclusion. So, that will be the best among this. Okay. So,
Yes.
this is not wrong. Okay. But the best will be the diagnosis is by exclusion. Okay, diagnosis is by exclusion. Okay, so pregnancy is not the cause, termination is not indicated, visual outcome is same as in non-pregnant. Okay, then CSF, that is a normal composition, diagnosis by exclusion. Next.
Which of the following findings is required to diagnose IH? CSF opening pressure less than 200 mmHg2O, abnormal CSF composition, normal neuroimaging, focal neurological deficit, E seizures. It is C normal neuroimaging.
Yes, normal neuroimaging. You have to exclude the tumor, hydrocephalus. Imaging should be normal. Okay, core part of the modified Dandy criteria. Okay, so take home message: obese woman plus headache plus papilloedema, lumbar puncture pressure more than 250 millimeters of water. Imaging is normal. Acetazolamide is the treatment of choice. Main risk is the visual loss, and delivery is for obstetric indication.